Okay, good afternoon, everyone. My name is Jeff Jutai. I'm a professor of health sciences at the University of Ottawa, and I've been I like to say, a lifelong member of AgeWell. I've been a member of the AgeWell network since it first began, and I'm delighted to be here today to chair the session, our first session here on Challenge Area Healthcare and Health Service Delivery. So we're excited to have three epic presentations as part of today's session by this following speakers: Hadi Hojjati, Olive Bryanton, Mayank Kalra, and Karen Young. Now, just before we begin, just a couple of housekeeping items. Challenge area presentations will take place on Zoom from 1 to 2:30 p.m. Eastern Time on Tuesday to Thursday this week and every day next week. On Friday, May 26th, please join us for an epic conference workshop entitled Addressing Barriers and Facilitators to Technology Implementation, that'll be presented by the Executive Director of the Center for Implementation, Julia E. Moore. Those who attend the full session live will receive a certificate of completion. So I encourage you to check out the AgeWell Epic Conference webpage for additional details and registration information. Some more housekeeping items. Today's session will be comprised of 3 oral presentations, a 5-minute Q&A session following each presenter, and then an overall discussion with general Q&A that places the presentations in a larger discourse and addresses potential research impact. All attendees are encouraged to use the Q&A box on your Zoom screen. Use the Q&A box to answer to ask questions rather, leave a comment on a question, and upvote questions that others have submitted. The session is being recorded and will be available for playback. Links to playback will be posted on the EPIC conference webpage and the AgeWell YouTube channel. So I hope that that information is clear. And the folks, our AgeWell facilitators, Allison and so on, if I've missed anything in terms of introductory remarks, maybe you can cue me.
You're good to go, Jeff.
We're all set to go. So if we're all set to go, and we have our presenters with us. So let me just there we go. Then we can get started, and I'll be keeping time as well, just to make sure that we stay on track with the presentation lengths and then the Q&A sessions. So to begin, we have presenters number 1, Hadi Hojjati and Olive Bryanton. Hadi received his bachelor's degree in electrical engineering from Sharif University of Technology in Iran. He started as a student at McGill University and fast-tracked to PhD. Hadi is researching on the development of deep learning and anomaly detection methods for processing biomedical signals. To this date, he has published several papers in high-impact peer-reviewed journals and conferences. He has received several prestigious scholarships to support his research and studies, including McGill Engineering Doctoral Award, the Quebec Research Award in Engineering and Technology, and the AgeWell Graduate Student and Postdoctoral Award. Olive Bryanton joined AgeWell's Older Adult and Caregiver Advisory Committee in 2018. As an educator and passionate advocate for older adults, Olive was instrumental in the establishment of the first multi-purpose senior center in PEI. She was also instrumental in the establishment of the Seniors College affiliated with the University of Prince Edward Island and served as the first president. Olive has received many honors in recognition of her advocacy work with older adults and lifelong learning, including an honorary degree from the University of Prince Edward Island and the Queen's Diamond Jubilee Medal. She is currently a lifelong learner and defended her PhD in 2018. So I'll turn things over to you two, Hadi and Olive. You have 10 minutes. And when you see my face appear again, you'll know that you have about a minute left to wrap up. Okay, so over to you.
Okay, perfect. Thank you very much, Jeff. So I'm Hadi Hojjati, and I'm a PhD student at McGill University. Today, I'm going to talk about my project which is titled as Blood Pressure Estimation in Health Smart Homes Using Multimodal Machine Learning. And then after me, Ollie will also talk about stakeholders' view on this project. So before I begin the presentation, I wanted to locate my work in a larger context. So our work is basically trying to address a very important challenge and tries to contribute to health monitoring. So health monitoring is essential in ensuring the healthcare and also the timely diagnosis of many conditions that can be very costly and otherwise, if we could prevent them, it would actually not happen. If we could actually detect them in their early stages, it would save a lot of money. And it could also help a lot in ensuring a better quality of life, especially for elderly adults. So traditionally, health monitoring was done using some invasive methods. For instance, we could actually note blood pressure estimation using cough-based methods, as you can see in the picture, or also recording the ECG signals using invasive devices. So these methods, as I said, they usually require user intervention, and they can also be done only in the presence of a caregiver. And the thing that it clears a barrier is that these two important issues makes them an impractical solution for continuous monitoring of health systems because they, as I said, require the presence of a caregiver, and they cannot actually be done without the presence of the user intervention. But even though that these challenges exist, because of the fact that they are accurate and reliable, they are still dominant in health monitoring. On the other hand, we have the unobtrusive methods. These unobtrusive methods, unlike the traditional methods, they usually do not require an active participation from the users. For instance, a very common recent, I would say, invention is the smartwatches, where it can actually monitor the important and vital signs, such as like blood pressure or heart rate from the patients without them needing to intervene or do anything which is not comfortable for them. And they also do not need the presence of caregivers. So it is very, very important development in ensuring that especially elderly adults can have a high quality independent life. But the important thing about them is that these two important properties, on contrast with the traditional methods, make them usable for continuous monitoring. And continuous monitoring is actually key to ensure that we have timely diagnosis, because the traditional monitoring can only be done after a symptom is usually seen, or if the user is going to checkups in a timely fashion. But on the other hand, the continuous monitoring can enable us to have a way to always monitor the health condition of the users. But the important issue that we currently have, despite all of these good things that unobtrusive monitoring can provide us, is that comparing to traditional methods, they do not provide an accurate and reliable estimation. And in order to actually solve that issue in this project, we are going to put our focus on very specific way of unobtrusive monitoring, which is unobtrusive health monitoring using health smart homes. So health smart homes are basically they are infrastructures that are actually installed inside the homes and also the apartments, and they can be comprised of smart furniture like smart chairs or smart tiles, and most importantly, some cameras or some color sensors like the infrared sensors that can also record the activity and the behavior of the users. So these health smart homes, they are actually an obtrusive way of health monitoring. So they provide a feasible solution for continuous monitoring. And on the other hand, the important issue that we currently have with health smart homes is that most of the research and development in these new inventions, they are actually not related to the health application of smart homes. They are mostly done, and most of the commercial usage of them is actually for making the life easier. And the health part, especially the health part for the elderly adults, is not adequately explored. And it's a research gap that we are trying to address in this project. So in order to actually narrow down our focus, we are also in this project going to focus on estimating blood pressure. So blood pressure is an important vital sign that can be used for detecting many important conditions, like, for instance, hypertension, which is a very common condition, especially in elderly adults. And in this project, we are actually using the prototype that it's actually developed in a partnership with UHM. And the data set is actually collected from 11 subjects. And in this specific project, what actually makes it unique is that we also recorded the ground truth blood pressure using the invasive and traditional methods, so that we can have a basis to compare the results that we get from our model using the ground truths. Otherwise, we wouldn't have any, like, I would say, anchor to compare our results and our analysis to. And in this specific project, we are having the videos, as well as 4 approximate signals: ECG, BCG, PPG, and EMG. And the important thing to note that we actually recorded all of these, as well as the ground truth blood pressure. But in the analysis that we are going to make, we are not going to use the ground truth ECG, BCG, and PPG, but we are going to use the data from these sensors to actually approximate them. So basically, our goal is to develop an algorithm and a method that can actually detect blood pressure using only the smart home infrastructure, without needing any invasive way to actually get the blood pressure. And here in the figure below, you can see basically a very simple diagram of how this recording is done. Basically, the whole idea behind this is that we can put some electronic devices in these chairs, and they can actually, with like proper sensor configuration, they can actually approximate these different signals like ECG, BCG, and PPG. So there is also another important thing to mention that kind of motivates our approach. So our approach, which is like unobtrusively using like cameras and sensors, finding the blood pressure, has also a scientific ground to it. So when the blood is actually flowing through the veins, and if we just put like a sensor or like a light sensor, like an emitter and detector on that, the changes in that, like the signal that we are receiving, can actually be a cue for us to approximate the blood pressure. So like here on the top right figure, you can actually see a very like naive setup of that. But the important thing is that this blood pressure, when it's actually flowing through, it should go through the skin. And this is something that can deteriorate the signal in a huge potential. So the signal that we get through this light sensor will not be a clean signal, but because of this, I would say, scientific background that's under this like reflection of the light and the sensor behavior, we can actually have this motivation that part of this noisy signal is actually capturing the blood pressure. Another important development that can also motivate our work is that there is, I would say, a substantial literature existing on detecting PPG, another vital signal which depends on the blood volume, through images and videos. So here on the bottom side, we can see like a very abstract way to measure the PPG through the face videos. In this case, we are focusing on only a part of the face, and this part is actually done all by like image processing techniques. And then we extract these signals, and using the methods that are developed in the literature, we can actually extract the PPG signal and remove the noise and other unwanted signal from that. So all these 3 important, I would say, literatures up until now can actually motivate our work for blood pressure estimation using the smart home sensors. However, there are some challenges that actually limits this application so far. So one of the important things is that, as I said earlier, like the sensors are noise contaminated. Noise in our context is any signal that is unwanted. So it can basically be the noise as if you are familiar with it. So Jeff, I see your screen, but you're muted.
You have about a minute left, Hadi.
About a minute left. Okay, perfect. And also, so the other things about these challenges is that the blood pressure itself is a very complex signal to measure. So here you see that the signals that we have are very noisy, and much of this noise is actually coming from the movement of the patients. So in our approach, we are going to use a unimodal approach, meaning that we are going to use both the video and also different sensors. And our hypothesis is that if we use all of these sensors together, we can have a better approximation comparing to just one sensor, which can be very noisy. And so far, we have got some preliminary results. These are like preliminary results using the methods that are already in the literature, and we showed that the multimodal approach can actually get a better result. And for the present these like numbers, they are actually the reconstruction error. So the less, the better they are. So we can see that the multimodals, in all the methods, we can get the better result comparing to just feeding the signal, the single, I would say, signals. And finally, so currently we are working on developing the better methods, but there are also some other aspects of this work, like the privacy and the ethics, that can be concerning. So I'm going to pass my presentation to Olive to shortly talk about these challenges as well. Thank you.
Thank you, Hadi. The things that I focus on most is, you call it non-invasive, but for an older adult, one of the things they'd be concerned about is their privacy. So the camera would probably, you would be questioned about that. Also ethics, you know, who's going to see this? Is my face going to show? Would be other questions. The ease of use, when I looked at the chair, I thought it's lovely, but where are the arms? Older adults would need arms to be able to get up and down. Also, the height of the chair is very important because older adults shrink as they grow older and your legs get shorter. So you couldn't even put your feet on the floor with some chairs. So would really have to look into the chairs. And the information they need, it would be really helpful for them to have written information.
Thank you very much, Olive. So these concerns are actually the things that we are working on in the remainder of this project. So at this point, I would like to pass it to Jeff. So if there is any question, I would be happy to answer it.
Very good. Thank you, Hadi and Olive. That was a very nice presentation, very clear. And we're just going to have a look at the Q&A. Just a reminder to folks, please, if you have any questions, pop them into the Q&A box from your Zoom screen menu. And just maybe while we're waiting for an opening question or two, maybe I could just go back to Olive, if that's okay with you, and just ask you, tell us a little bit more about how you came to get involved with Hadi. You know, how did you get started working with him on this project?
Well, I was invited by, I was asked by AgeWell if I would be interested in being involved. And because I do have a curious mind, and I am, as a human being, I think I'm always fascinated with the rate that knowledge, especially technology, is advancing, and trying to keep up with what's going on. So this is a great opportunity to be able to learn about some of the new things that are happening. And I thank Hadi for inviting me in. Great.
We have a question for Hadi. How will you integrate this helpful feedback that you're getting from Olive? How do you actually propose to integrate it into your into further development of your system?
So actually, that's a very good question. So one of the important concerns that Olive also brought up is the part about privacy and ethics. So having a camera, it's something that maybe many people are not very comfortable with. But the thing in our project is that we are going to focus on just the blood pressure. So currently, we are actually researching the ways that we can either eliminate the camera altogether, or use, for instance, only like the part, like the output of an algorithm that can mask the face and only outputs the physiological signal. So we do not store any information related to the face. So these are the parts that we are, like, at first we did not consider in our project. We just like recorded the videos, but now after we got the feedbacks, we are trying to see if we can actually like address these concerns by masking the data or not saving the video data or the face data. And also another thing that we are currently working on is to just work on the video from hands, which does not bear any like face or any other identifier from the users.
Okay, thank you. We've got time for maybe another one or two questions. Got one here from Gehan. How do you get access to this technology, Hadi? How does one get their hands on it?
Yeah, that's a very good question. So the technology that we have is basically this smart home that was developed by my research supervisor, Prof. Nargis Salmanfard, during her time at the UHN. So they actually developed like this project at first was just like developing like the sensors and the furniture. But after that, we got in contact with UHN and we decided to actually continue this project by also trying to develop the algorithm for extracting the blood pressure and other vital signs as well.
Okay. And we've got another question here from Patricia. Can you recommend a particular smart watch or are they all the same?
So the smartwatches, like currently the important thing is that most of the current smartwatches, they are not targeted toward the elderly adults. So they are basically like a general smartwatches, such as the ones that are made by like giant tech companies such as Apple or Samsung. And they do have the heartbeat, I would say, or other vital sign approximations, but they are not well integrated into the needs for example, currently we are seeing companies like Apple, they are getting their systems connected to the caregivers. So we are seeing some very important like cases where those smartwatches could actually be used to save lives. But currently, I wouldn't say there is any particular smartwatch or model that is superior to other ones. But what we are trying to do is that we're trying to have a very specific target in mind and try to address that. And I would say other smartwatches are also built based on that. So they all had a target and they tried to actually come up with a solution to that.
Excellent. Okay, thank you. Hadi, I want to move on to our next, I want to make sure we do have enough time for the next two presentations, sure. But just a reminder that we're going to have a general question and answer at the end. Lots of time involved there. So if we didn't get to your question for Hadi and Olive now, please hold it or repeat it when we get to the, at the end of the third presentation. So at this point, I would like to introduce Mayank Kalra. Mayank is a mechanical engineer at the University of Waterloo who studies how technologies can help prevent musculoskeletal injuries in the field of trauma biomechanics. Previously, Mayank worked on knee braces to reduce injuries in younger adults. Since joining the Department of Kinesiology and Health Sciences, Mayank's research interests have shifted to the quintessential field of falls and fall injury prevention in older adults, focusing on real-world implementation. Mayank's collaborations with the Schlegel Research Institute of Aging look at safety floors, hip protectors, and now bedside mats to help reduce hip injury risk in retirement and long-term care of older adults. So without further ado, over to you, Mayank.
Thank you very much, Jeff, for that detailed and kind introduction. Hi, everyone. Thank you for inviting me. And I want to start and present my work on hip protectors and how we're using simulated hip impacts to better understand them. So it's no mystery, or it's painfully obvious that falls are an endemic amongst Canadian as well as global older adults. And while fall rates are fairly common, as the population increases and ages, falls are increasing, hip injuries are increasing, as well as the strain on the healthcare system are all increasing. So the need for interventions is greater than ever. There's a few that are around for hip injuries, including hip protectors, as well as safety flooring. I have experience with all of these, but today I'm presenting on bedside mats. And theoretically, this is a really easy problem to solve. If you reduce the impact force on the femur or at the hip, you reduce the injury risk. So mechanically, it's also kind of easy to explain. You just make the ground softer. Several studies have shown this. When you fall on softer ground, whether it's indoors or outdoors, injury risk gets reduced. But there's a very, very intricate balancing act. And that is the softer you make it, the more attenuation or the more impact force reduction you have. but you decrease balance, and the opposite happens with harder. So if you think about it, you fall on, I could put a mattress, we can cover every single floor in the world with a mattress, but it really wouldn't be easy to walk on, especially for older adults with balance issues. And likewise, I can make it harder, but make every single floor, concrete, and it would improve balance a lot, but attenuation would greatly reduce, and you'd end up having more risks. So there's been a bunch of work on bedside mats in the lab. This is a pelvic drop test, and it doesn't have a mat shown here, but basically you attach an individual to a sling and drop them. You would place a mat right underneath them and just measure the impact force with and without mat. This is a surrogate hip. These are leaf springs that represent a pelvis. This is a foam hip. You basically drop it from a height on the mat and again, measure the impact force. And the right image is exactly what we did in this study. So we ended up with our objective. It was to just characterize impact force attenuation in a bedside mat used by our care facility stakeholders, Schlegel Village, as well as its future viability. It was important to go and get an actual mat that was used by Schlegel Villages, because a lot of studies will take mats that they find online or from any store, but we took one that we went into a Schlegel care facility at Waterloo at University Gates. I spoke to a registered kin there, and she handed me the mat that they would actually give to the residents in retirement. So this is ultimately the setup. And here I want you to bring your attention to our hip. We didn't use a foam hip, we used a gel hip because it's more representative of the human anatomy. And this effectively here is the soft tissue around your femur. It's basically your hip area. There's a metal plate in here, and it represents the curvature of the femur. And right here, there's a small little load cell that as you end up getting impact, this load cell just measures force on the femur. So the second part that I want to bring your attention to is this drop tower. So that's the hip, there's the femur. This is a surrogate pelvis. These springs reflect the stiffness and mass of a 35 kilogram pelvis, which is representative in older adult women. So ultimately what we ended up having was impact trials with and without the mat. You can see that here on the left and right. So you can see on the left, that's basically the drop tower without the mat, and that's with the mat. And we have a bunch of sensors measuring force throughout. I'll play those again. So that's without, and that is with the mat. And if you are perceptive, you might notice that the hip is on the ground and the pelvis is falling. So the system is actually inverted. So it's not like the person is falling on the earth. It's like the earth is it's like a 35 kilogram earth is falling on the person, and it doesn't really make a difference. You just flip your system. It's no difference on the actual force. So you might have noticed in the last one that the fall height was pretty high, and that represented our third condition, which was the high fall distance or high fall velocity. We included three distances, low, medium, and high, that included fall heights of 5 centimeters, 20 centimeters, and 44 centimeters. They're meant to reflect all different types of fall situations. And the high one, 44, is typically what you see of falling out of bed or falling out of a chair. The low and medium are more of, 5 centimeters is almost nothing. It's like that much. People are like, how do you fall? But this is more if an older adult starts to fall, braces themselves, but then cannot catch themselves and ends up falling from a lower or closer height to the ground. So finally, we just basically have impact force at that femur load cell. The gray represents without the mat, the black represents with the mat. And typical of previous studies, as fall height increases, the mat does more. As you can see in the highest fall height, that there was the greatest attenuation, but overall there was attenuation in every single simulated fall height. So just to conclude, this bedside mat reduced impact forces. It is viable for further work, and more importantly, it's reflective, or it's affirmative, that something that we took from Schlegel villages that they would put on a resident's bedside would end up reducing impact forces at the hip and reducing hip injury risk. So this was a pilot project, and there's a few directions for this. The first one is to get more mats. We took this from one site. I'm currently working with Schlegel to get different models of mats that they all use, maybe 2 or 3, and to test those. But also we have a mathematical model, a computational model that can predict hip fractures. And by taking the previous results and putting them into this model, I can see what would theoretically happen in a population of 100,000, 1 million older adults who all fall. And I can see what percentage of them would end up with hip fractures, or how many hip fractures would be reduced with the addition of the mat. And finally, balance studies. So I mentioned balance is something that we really need to monitor with bedside mats or any soft surface. And so doing a study with older adults or testing balance can really help better inform clinical practices. Thank you very much.
Hey, thank you, Mayank. You're actually a little bit early, in terms of the time allotted. Were there any other comments you wanted to make just before we open it up for questions? Any other?
No, well, I guess I'd like to thank AgeWell for this opportunity, my funding award, as well as Schlegel Villages and the Research Institute for Aging at the University of Waterloo for their collaboration.
Okay, thank you. Just a reminder to everybody out there in the ether, please, when you're posting questions, try to identify the presenter that you are addressing your questions to. That'll help us out a lot. Okay, so let's go over to questions. Any questions for Mayank on his presentation? Maybe I could just ask, Mayank, I don't think you had a chance really to elaborate, but could you comment briefly on the extent to which your approach here to measuring these forces and so on is an advance over existing methods? What would you identify as the particular advantages?
So one of them is that, let me go back to that slide here. So one of them is that the CSA has standards for drop towers based on the fall heights. You can see the markers here. There's one, there's a second one, there's a third one. Those are the 3 heights on what heights to drop, as well as the construction of the pelvis hip and the surrogate pelvic femur. So it's just, my supervisor, Andrew Lang, has spent a lot of time and resources to try to make this CSA compliant, and just to make sure that our results reflect the results of every other lab out there. He's upgraded his own drop tower to do that. So that is an advantage, because when you end up comparing a bedside mat to, let's say, another model or a competitor, or even the same mat to another group, and you get different force values, then you kind of start to question, what is the mat actually doing? Or, is it beneficial? Or, this is a very controlled and very specific experiment that you kind of have to make a lot of assumptions when taking it to clinical practice.
Okay, thank you. All right, we have a question here from Razak, who's asking, what are the mats made of? Fiber or any material specific that will help reduce or characterize impact force?
So I don't know the exact material composition or properties of the mat, but it's mostly a polymer or a rubber. And there's very little difference between bedside mats and anti-fatigue mats used for ergonomic reasons in the workforce. If you've ever gone to like any store or like a grocery store where any employee has to do long duration standing, you'll often see them standing on like a black mat just to reduce the amount of impact forces they get in the legs or the spine. This is a very, 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 very similar construction to that.
Very good. Another question or suggestion here, Mayank, could you tell us about working with older adults or other stakeholders in your research? Have you received any interesting feedback on your work from stakeholders?
Not on the bedside mat project, because this is just pilot study, tested a mat. We currently are looking to recruit older adults for the balance. Schlegel Villages, I presented this to them, I think in October or November. They were really interested about this because we were taking their product and showing them how it worked. We got huge feedback, and we're kind of working on a grant with them to push this work out further. I got a lot of positive feedback from older adults regarding the safety flooring that I did. That was a pilot project at University Gates, where they put floor in 5 suites all across the floor, kind of do the same thing, reduce the impact force. A lot of positive and a lot of room for improvement. So overall, they're very receptive to anything that you try to do to reduce hip injury risk.
Excellent. Okay. We've got a note here from Brian. Brian says, great talk, Mayank. You mentioned a trade-off between soft mats and balance. Can you speak a little about where the mats came from, the facility? For example, were patients walking on these mats often?
The mats come from, it's a Drive 2.0. I can post a link if anybody's curious. It's a Drive 2.0 mat. I'm not even sure if it's meant for older adults or if it's meant for ergonomic reasons. I do not know if patients were walking on these mats often or at all. If that's something that this company tested, but that's something that we want to test. Regarding the next question, the price range, the website says it's about 180 US.
Sorry, that was 180 US? Is that what you said? Okay. All right. And we have Gahan. As price-wise, will it be affordable, especially if elders don't have enough income? So would you peg that price? Would you describe it as an affordable?
In terms of the 3 that I put, this is honestly the most affordable because safety floors are in thousands, and you can only put it in a suite, and then it's in the suite. So you have to give the suite to the older adult who needs it. This is something that can kind of be relocated to any suite depending on need. Hip protectors as well. They might be more affordable actually, depending on the model, but they come with a whole slew of challenges, mainly, comfort and function, as well as, just usability. Hip protectors, one of the problem with them is that they need to be laundered so frequently. So they end up with this whole process of how do you actually get it into laundry service and back to the older adult in a timely fashion. So affordability for these things, it's always a challenge. There are, and I compare it to a car. Lots of people, you can go and say, would you pay extra for this security feature in a car? Some people might not. They might consider themselves good enough drivers and not do it. Whereas others would be like, oh yeah, I'll absolutely do that. I want that extra thing. I want it there. I want that safety blanket. There's some older adults where 180 US is to, reduce months of rehab is absolutely nothing. Whereas others are like, I'm not really mobile, or I never fall. It's, not really for me. So Schlegel does pay for some of these things depending on the, whether it's long-term care or retirement. But it's always a conversation with the older adult.
Okay, and we'll let Gahan get in the last question for this round. Are there any health issues that elders shouldn't, where elders shouldn't use these mats? If you're considering things like worsening hip or spine problems, any issues there?
No, research has shown that there's nothing actually wrong when you are standing on the mat. And it is more comfortable than standing on the floor. The issues come in with the beveled edges. So when you try to go from floor to mat, and that difference in height, that can be a tripping hazard. And the other issue comes with any mobility aids, such as walkers or wheelchairs. Those are sometimes difficult to maneuver on the mat. There's a third bigger issue of the size. Some of them are too narrow, that only one wheel of the walker or mobility aid goes on, and then you kind of have like a tilted or slanted mobility aid. That's a pretty easy fix, but the biggest issue is the change from one surface to the other.
Very good. Okay, thank you again, Maya, for that great presentation. Just a reminder to everyone, if you want to pose questions, please try to identify the presenter that you'd like, who you'd like to address that question. And we'll carry any unanswered questions, as many as we can, into the final Q&A session after our final presentation, which is going to be by Karen Young. Karen is a research student at the Center for Digital Therapeutics at the University Health Network and a second-year MSc student in Health Systems Research at the Institute of Health Policy Management and Evaluation at the Dalla Lana School of Public Health, University of Toronto. Her interests lay at the intersections of health equity, decolonial and social justice theory, and digital health design, development, implementation, and evaluation. She holds a CIHR Canada Graduate Scholarship, Master's, and an AgeWell Epic AT Fellowship. So we're very pleased to have Karen here to present. And Karen, whenever you're ready, please go ahead.
For sure, and I'm very pleased to be here. Thank you for having me. As Jeffrey mentioned, I am a student in my second year of my master's at U of T. I am also a research student, and what my project today and what we're going to look at is actually about a product that's being developed at the Center for Digital Therapeutics at University Health Network. It's a research and development group focused on building novel digital therapeutics for chronic disease management. So our group looks at innovation between technology and healthcare, from ideation to impact. And we're also going to do things a little bit differently from the incredible presentations that you just saw. So we're going to switch tacks and talk about systems, structures, and the social determinants of health. So the project and this presentation focuses on one of the most commonly diagnosed cancers in Canada. So prostate cancer is the most prevalent non-skin cancer diagnosis in Canadian males. And 99% of these diagnoses occur in folks over the age of 50. And you've probably heard that you're more likely to die with prostate cancer than of prostate cancer. But survivors often have post-treatment challenges that can take a really long time to resolve and are difficult to resolve in full. And part of that is because current follow-up care systems aren't set up to address these quality of life issues. They're often more geared towards addressing recurrence of disease. And so one pathway that's being put forward to address these quality of life issues is digital health. And so to leverage digital health for survivorship care, the CIHR funded No Evidence of Disease, or NED Clinic, as you can see, was created to transform the current model of care through digitization. And it's actually currently in clinical trial in Ontario, Nova Scotia, and Alberta. So the NED Clinic was designed to let patients report their outcomes or patient-reported outcomes, things like blood test results, symptom surveys through the NED application, while clinicians would be able to provide asynchronous care through the same application. So it was developed in Ontario by a consortium of stakeholders housed at UHN. But at the same time, we also need to understand the wider impact of digital health technologies, just like NED, on different communities in Canada, because not everyone and not every community will have the same access to these technologies. And I'm sure as a result of the pandemic, many of us are familiar with the digital divide, which are the relationships between social inequities and digital technologies. So things like demographics, culture, healthcare system processes, access inequity, or what's more formally known as the social and structural determinants of health, are often not taken into account when digital health tools are designed. And so another way that has been put forth as one way to make sure that these technologies are more accessible is through cultural adaptation. And so cultural adaptation uses a cultural lens to leverage the benefits of these existing interventions, save resources for development, and spread benefits to communities that might not necessarily have access to these technologies. But at the same time, I'm sure we all know that culture changes, right? You know, how many of us are in TikTok? So cultural adaptation frameworks that define culture based on kind of one point in time might not really be able to fully reflect or handle the complexities of culture and how they change, especially when we think about diaspora communities in Canada. And so one such community is the Chinese Canadian community. It's an incredibly diverse community because of many, many decades and centuries of immigration from all areas of China and other international diaspora communities. So it's very diverse. It's not a monolith. And so Chinese Canadian prostate cancer survivors illustrate these really complex intersections of culture, technology, and health. Previous research indicates that Asian prostate cancer survivors have little involvement in formal research, and they're also less likely to access care and more likely to report lower satisfaction with the care that they do receive. So in reflection of all of these issues and all of that context, we wanted to explore and understand how might we co-create pathways to equitable and accessible virtual prostate cancer survivorship care for Chinese Canadian survivors through the possible, in quotation marks, cultural adaptation of the patient-facing Ned Clinic application or the app for this community. And so it was really important that we started by understanding the layered nature of these constructs and think about how might we improve the lack of voices from prostate cancer survivors from this community in a really equitable and empathetic way. And this study was also designed as the first phase of a larger research project that used the information here to create a working prototype of an adapted prostate cancer survivorship application. So when we think about the determinants of health, the social and structural determinants of health, it also makes us ask the question, why do they exist? And really that's a question about settler colonialism, because ultimately to live in Canada is to live within settler colonialism. Our beliefs, thoughts, and behaviors about race, ethnicity, and culture are all caused and affected and intersected with our understanding of the governance systems that we live in, the social structures that we live in, the places that we live in. And so when we think about settlers are not immigrants. Settlers are people who implement their own laws and understandings of the world onto stolen land. So to resist settler colonialism requires us to reclaim the term immigrant. Immigrants are people with ancestral roots outside of Indigenous lands who are beholden to Indigenous laws and epistemologies, or a non-Indigenous person. And so living as an immigrant and practicing immigrant health research can be redefined as the study and practice of how non-Indigenous people can live well according to Indigenous ways. So the guidance that we found in Indigenous and Black feminist theorizations was used to develop a really multi-level holistic approach that tried to acknowledge the multiplicity and complexity of the systems that we live in. And so from this redefinition, we also thought about where folks have immigrated. So the Chinese Canadian community, or a really large Chinese Canadian community, lives in the Greater Vancouver Regional District, which is located on the territories of the Tsleil-Waututh, Squamish, and Musqueam First Nations. And so the creation of this community and the healthcare systems, everything here results from the history of settlement on these lands. I myself am from Vancouver. I was born and raised there. I went to UBC. And so, I'm very familiar with this area because this is home to me, but I also know that this is stolen Indigenous land. And this is also where the folks that participated in this study live. This was a community-based participatory research study. So it was completed in partnership with a Chinese survivor peer support group and a supportive care program that are both located here. And so what we found was that surviving prostate cancer weighed really heavily on folks. They didn't really have an understanding of how to cope, or felt like they weren't taught how to cope with the emotional impact of having prostate cancer, especially because it is a chronic disease. It lasts for when you're a survivor, you're a survivor until the end of your life. And you deal with things like recurrence, you deal with quality of life issues. And so the care that they received from the system did not appear to care for them in the way that they wanted to. In addition to this, the information that they received during their interactions with the healthcare system, with their providers, didn't quite fulfill their expectations. And there was a really interesting split here between folks who wanted as little information as possible and folks who wanted a ton of information. But in either group, both groups felt like they were responsible for ensuring the quality and the accuracy of the information they received, but they also didn't feel like they could do that because they weren't clinicians. And so unmet needs matched what is found in the wider literature about better access to care, shorter wait times, more continuity of care. But participants felt like they really weren't allowed to, or they were powerless to talk about what they needed. And so they really individualized the responsibility for these more systemic concerns. And the ways that folks dealt with these challenges was to rely on familial support. It was also found that fluency in English and a higher formal education were helpful as well, but not everyone has access to that. And so when we think about technology, a lot of folks, when thinking about the ways that virtual care impacted their experiences, thought that virtual care really resulted in fractured care, not continuity of care. And that continuity of care and then strength of that connection with their provider was really correlated with how safe and comfortable they felt talking to the providers and getting the care that they wanted and needed. So when we think about the takeaways that we can gain from this research is that when we think about systemic inequities, eating bitterness or really trying to cope with these systemic challenges is not an effective approach, because these are problems and challenges that are experienced by many people across many different communities. And so in terms of thinking about the ways that virtual care and digital health can improve the systems and the healthcare systems that we have here, we're really looking at trying to strengthen them through technologies that provide privacy and accessibility, accountability, relational accountability, and responsibility. And this perception of virtual care as only better than nothing really reflects a perceived lack of care. And so when we think about designing digital technology, it's really about critically reflecting on the structures that these tools are designed in to examine if we're designing tools and places that allow for good care, because ultimately it's not going to be a technology that cares for us. It's how we care for each other with technology as a tool. And that brings me to the end of my presentation. Thank you very much.
Okay. Thank you, Karen. That was great timing and a fascinating topic area.
Thank you.
Let's start with, oops, just lost my chat box there for a sec. Let's see if I can get it back. There we go. And the first question we have is actually from Allison. Karen, do you have plans to work with Indigenous people or communities to help integrate methods such as ways of knowing and being?
That's a great question. And I think that's also a question of representation. Part of the reason why I did this project is because I am Chinese Canadian. Like I'm from Vancouver. My dad is basically in that cohort of folks who is at risk of prostate cancer. And so this is a topic that's really close to my heart. But part of the reason why it was important to me and to the folks that I work with to understand how we can live well as immigrants, folks who are living well according to Indigenous ways of being and knowing, is because it shouldn't be up to just Indigenous folks to think about how we can kind of restructure the ways that we live to live well with each other and in healthy ways. And so our group does work with Indigenous communities, does a lot of community consultation to do things well. In terms of this specific project and in my own career path, I'm not quite sure what that would look like, but this project specifically is kind of scoped to look at the Chinese Canadian community and how this technology might be adapted to serve their needs. But more broadly, because it takes a structural approach, the idea is hopefully to use what we've learned in that structural analysis to actually improve the NED app as a whole, and hopefully benefit other communities made vulnerable, including Indigenous communities.
Okay. We have a question from Sienna. Does the NED program also address cultural barriers, such as language, barriers between the Chinese, Canadian patient and physician, et cetera?
So in terms of cultural barriers, I think that that might mean a lot of things, but I am going to focus on the example that you gave in terms of language. So language, you're correct. Language is a huge part of culture. At the same time, language can also be used as a scapegoat for why communication doesn't work, when it might actually be other things at play. Perhaps, there just isn't a good patient-provider match, or there's other accessibility concerns at play. But the way that language is considered in this adaptation of NET is it's actually communication accessibility. So it's not necessarily about language as culture, but language as a way, and language access as a way to increase accessibility to the tool and to providers and systemic interactions with the healthcare system.
Okay. Next question. Can you talk more about the challenges of promoting equitable ways of age tech in Canada for minority communities? What is one recommendation you can give to improve on these challenges?
That's a great question. I think from the work that I've done and from my perspective, it really is about relationship building as the very first step, because let's take the pandemic for an example, and vaccine rollouts, especially for communities made vulnerable. And just speaking to my own experience, there are folks in my family who are really skeptical and suspicious of the vaccine because they didn't trust it. They didn't trust, the government. So what was really most effective there was ensuring that, or, getting the message out and making sure that there is a relationship of trust that these communications were being built on. Because it's sort of one thing to receive this kind of wider message from a government or an institution, but depending on what your community and what your own experiences with that institution might have been like, no matter what the technology is or what the intervention is, if you don't trust the institution, you're probably much less likely to want to accept that intervention. And so really that relationship building and coming to the community and going there on their terms is really kind of the first step to rebuilding that trust. Because I think if we take, that social, structural, the historical perspective, there are a lot of really questionable things that these structural determinants have resulted in for these communities made vulnerable. And so repairing that relationship is really key.
Okay, and Karen, I wonder if I could just sneak in a question.
Of course.
My own here. Your findings regarding what the Chinese community, Chinese male members of the community concerns were in terms of unmet needs and unmet supports and so on. To what extent do you feel that they were unique or specific to that community in relation to or in comparison with the population of males as a whole, or with other ethnocultural groups?
Absolutely. And I think this is one of the things I would have loved to speak more of, but I think just in terms of trying to balance the material in the presentation, there just wasn't enough time. Interestingly, or I guess, something that we found in our study was that unmet needs actually mirrored the wider literature around unmet needs in the broader prostate cancer survivor community. What was, I guess, unique about the work that I did was, number one, it was the first study actually looking at the needs and unmet needs and challenges and barriers facilitators faced by this community, and just looking at the communication aspect and the lack of tools available, or the lack of power that participants felt in trying to communicate these needs to their providers. That was really kind of the impetus for trying to look at that structural lens as well, because the needs were similar, but there's just so little information, so little formal research and so little involvement of this community that we just didn't know before we did this work.
Okay. Would you say that group is more or less susceptible to stigma associated with surviving prostate cancer?
That is also an excellent question, but that isn't something that we looked at. So unfortunately, yeah. I don't think I'm positioned well to answer this question appropriately.
Fair enough. Fair enough. Okay. Well, thank you very much, Karen. That was excellent. And now I guess it's time for us to open this up. We have a general question and answer session. And so when you, please, if you want, I guess, are we just taking open mic on this, Allison? Just remind me, or are we just putting all the questions in the Q&A box?
In the Q&A box, please.
Yes, okay, so we can keep a record. And I've not been very good about pressing the answer live and type answer buttons. So we can try to go back through, and maybe I can just do this in reverse order just to get things going here. Just to open things up, and then feel free to jump in, you folks in the audience, with questions for the presenters. We had a question for Mayank. How many people was the solution tested with, and was it tested with different ages and combined with other health problems?
Thank you. So I'm not sure if they're talking about whether testing in terms of the manufacturer or us. I'll answer both. I looked online right now to see whether this was tested by the manufacturer or if there were any details. I could not find anything on Google Scholar or from the manufacturer if any other research group has tested these. So I'm not sure what testing the manufacturer has done. But for us, it has not been tested on people yet. We've just tested it with the surrogate hip just to see what happens in a controlled laboratory environment. So yeah, if that answers your question. Secondly, I'd also like to say that the link I posted was for the US website. When you switch to Canada, it turns out it's actually cheaper. So I can post the Canadian link as well.
Okay, we had another question for you, Hadi, from Edith. And Edith was wondering here, the bedside floor mats sometimes cause older adult patients with impaired and normal gaits to lose balance. Isn't a mat an added obstacle for such patients? What would be a solution for such individuals?
So that's a great question, and really the best answer is it's patient specific. Ultimately, a mat is a piece of technology, and like any piece of technology, you have to see whether it suits your needs, whether the risks or the benefits outweigh the risks from person to person. If I can share my screen, one way that they solved it with safety flooring is if you have the floor, and then if you have the mat, right, that transition can be kind of dangerous. So what they end up doing is they basically put a very gradual or a ramp leading up to the product, so that this change in height from here to here is so minimal over such a long duration that you can have a tripping hazard, here, but it's very unlikely to have a tripping hazard here. So that is one solution that they can do to reduce the tripping hazard.
Okay. Let me just see. I'm just going to have a quick scan here to see if we missed any. Well, here's a question for Hadi. Is there a web? Oh, that's the web link I think you just mentioned, isn't it? Is there a web link to where we can follow the outcomes of the project, of your project?
Yeah, so currently we do not maintain any like GitHub repo or anything like that, but we are planning to publish part of the codes in like open access journals, and also put part of the results in public as well. But currently we're not maintaining like any, like I would say, a live website or anything for that.
Okay, thank you, Hadi. Hadi, while we've got you just fresh from answering, I got a kind of a crossover question for you and for Mayank, because Mayank, you're doing work in connection with the Schlegel homes, right? Yeah. So my question is, the smart home technologies, such as the ones that Hadi was talking about, to what extent are those implemented in facilities and centers like Schlegel? Like, how far are we from actually seeing these things in real world use? These types of systems. So Hadi, maybe you can comment on the extent to which your systems or things like them already, we can point to examples of where they're being implemented. And then Mayank, you could comment on your awareness of the extent to which they're being used in at Schlegel, as an example.
So just to answer this question, so currently smart home technologies, they are actually a very like evolving field. So we can see that in the past few years, we are like I would say most important obstacle in developing smart homes is that their end price for the consumers is very high currently. And the most important part of that is because they usually require installation, and installing them within the current infrastructure of the homes, it is something that is expensive, and it also has like a huge labor cost as well. So, but currently we are seeing with the development of technologies like, for example, Alexa, smart homes, things like that, we are getting step by step closer to have these smart homes everywhere. But currently, like I would say the more realistic goal for our project is to have them implemented in the facilities, because this is kind of like a, I would say, viable investment for many of the health facilities, because many of the facilities, they already have the cameras and things like that already installed. So our like main focus in the project is developing an algorithm that can work with even like noisy data. So this is like the main goal of our project. And this can heavily, like I would say, reduce the cost, because then if we have a good processing algorithm, we don't need to have the best and like the most accurate sensors, which can reduce the cost by a lot. But to like sum up and answer the question, I would say currently we are just approaching to the phase where we can have these smart homes. First, I would say in the facilities, and then after that in the consumer homes.
Okay, Mayank, did you want to comment on that?
Sure. The question was how easily they could be implemented, or how much are they being implemented?
Actually, you know, just how much? I mean, is that stuff how quickly are these technologies actually moving into
Okay.
residential long-term care and so on facilities,
So
and assisted living and so on?
So to answer, quickly depends on the technology used, bedside mat versus safety floor versus hip protector. How much? I would say it's really hard to quantify, but I guess I'd say they're being used regularly, daily for residents currently. These two, this Drive 2.0 mat, they store them in the fitness center at university gates, and whenever a resident needs them, they just go into the kin or the nurse or the PSW will go into a fitness center, grab it, put it in the resident's room. So that's kind of like it's there, it's ready whenever they need it. Implementation for some of the other stuff, as I said, we implemented safety flooring in 5 suites at university gates. That was not a quick thing because they have to be, it has to be done during construction. University gates was a new build for some of the retirement suites, so it was done. It was done there. Hip protectors, I'm currently working on an implementation study with 2 Schlegel sites. So that also, like, it's slower than bedside mats, but it's there. Residents have hip protectors in their care plans, their care charts, and they're given them based on need by either the residents' acceptability or the PSW's ability to provide it.
Okay, thank you. Olive, can we go back to you for a minute, and could you tell us about the value, what you see as the value of working with researchers on projects? And and how about your role in your role as a government advisor? How do you connect that with this research?
Well, I'm not really a government advisor. I'd love to, but I think it's very, very important that the end user have input into the development. I mean, a product can be the best product ever, but if the end user is not able to use it, or it's not fitting their needs, then it's really no good. So I think it's really important to work with whoever your end user is. And I think that's extremely important. And I just want to mention to Mayak, a few years ago, I was working in falls prevention, and we were talking about hip protectors. And the people they were made initially for long-term care facilities, but the people who were coming to any showing events we had were the active seniors who were skiing and skating, and they wanted to remain active. So the hip protectors were valuable to them to remain healthy and not break a hip.
Yeah, absolutely. Based on need, right? For you use the technology based on what you need it for and how much of it you need. Absolutely.
Yes.
Just carrying on with this theme, I wonder if I can go back to Karen and Mayank on the issue of developing a trust relationship. How important that is, that a trust relationship between you and your older adult stakeholders, co-designers, in doing the research that you do. Maybe Karen, you want to lead off commenting on that one?
Sure. So speaking about this work and the work that our group does, I was quite fortunate that my supervisor had already established or started establishing this relationship with the groups that we work with. And what I think was really key for me was being really open to how the project might look like. You know, the outputs might not be what we originally thought they would be, or, you know, what we might have hoped that they would have been. I certainly think that when we started, we thought cultural adaptation, well, you know, there's frameworks and everything, and then we didn't end up even sort of doing what is known as a cultural adaptation, according to kind of the standard definition. So that was a surprise. And so that relationship of trust was also rooted in a lot of self-reflexivity, trying to develop that sense of self-awareness, and also trying to make space for understanding what the power differentials were, because as academics, you know, as researchers, there's often kind of this there can be a really lopsided relationship there. And so we really wanted to make sure that we were aware of that, and we tried to mitigate that as much as possible. And that's where a lot of the theorization actually came in handy, because we used our understanding of cultural safety to apply it to our relationship and the way that the study was run, and also intersectionality, sort of anti-oppression frameworks. All of those tools were actually really useful and actually very pragmatic for us.
Okay, Mayank?
So just to make sure I get the question, it's how to develop a trust relationship between the care provider.
Yeah, comment on, you know, when you're working with older adults and other stakeholders in the design and development of some of these technologies and systems, how important is it, the relationship that you develop, the sense of trust that's developed between researcher and your partner?
Yeah, it's probably the most important thing, more than implementation, more than the actual product, more than the budget. You know, to go in and my previous work was always, before I started working with falls and older adults, was always very restricted and very specific laboratory controlled environments. So one of the reasons I joined this group and Andrew is because he started doing this work that was in the real world, going into the site, and you're meeting the employees and residents there and trying to offer solutions to their problems. It's not, you know, you're not there for the research community, you're there for the residents. That's your primary focus. And I was very enthusiastic and also very reassured that when I started to work and collaborate with Schlegel, they were more concerned about how the research would affect the resident and the employees more than how it would affect, you know, their own personal, like corporate growth. It was, you know, like put the bedside mat in, but, you know, like who would take this, who would receive this, you know, is there enough for everyone, etc. So in regarding to trust, for the most part, when I've gone there and I've given talks or spoken to residents, they are very trustful of the advice that we give them, so much to a point where I have to be careful not to give them too much advice that they could, like, you know, because I'm not a physician, I can't really give them medical advice. So I've kind of had to dial that back, but they're overly trustful of research and the work that we do and you know, the service that we provide, as well as Schlegel. They often feel like research is the thing that helps them make, educated decisions and quantitative, objective decisions on where to go next. I'm pretty sure if I did this study and this mat did not reduce peak impact forces, it would change their decision to immediately stop giving it to residents. And something in the model is the model has, people of all different ages, between 60 to 100, males, females, different BMI, different bone mineral densities. So we can kind of start to figure out who exactly it should be targeted to. And that would influence Schlegel practices. So overall, I think the trust between research and Schlegel and research and resident, it's very mutual and it's very excessive. It's very large. It's the most abundant thing in our professional relationship.
Mm-hmm. But you raise a very good point when you mention that you're not a physician. It's a question I actually would like to hear from all of our participants on. To what extent, though, do you feel that any advice you may be giving, or is it a concern how it might relate to the advice they're getting from physicians and other healthcare providers? Or do you feel that what you're doing is well integrated, is synergistic with the kind of advice on health and well-being that they're getting from their primary care providers? Whoever would like to go first on that, please just go ahead.
I'd be happy to, but also if Hadi or Mike want to go, I'd be.
I can go last.
Yeah, go ahead, Karen.
Sure. So I think that's actually that's a great point that you're bringing up, and we actually had some challenges with this because one of the things that we found was that this was really the first time that a lot of the folks that we work with actually felt comfortable talking about the challenges that they faced. And part of that is because we emphasized boundaries. We emphasized that, this space was for us to learn from whatever they wanted to share. It was really up to them. It wasn't going to be like a sort of directed, this is what we want from you, but we're really interested in your experience and how we can improve things. And so people kind of really, really shared. And so that sometimes would also result in questions that we frankly just were not positioned. It was not appropriate for us to answer them, same as Mayank. So part of what we did here was we really emphasized sort of the nature of our relationship, like it is, sort of a co-researcher, co-design, but also like there is that research participant element there. And so like the work that we're doing here is very much about the experience. Like we're not able to give that clinical or medical advice because that's not where our expertise is, and it wouldn't be appropriate for us. And it's not fair to you either, because we don't have that training. So we, and that was a really key part of actually building that trust, because we wanted to make sure those boundaries were really, really, really clear and we weren't going to try to overreach them.
Okay, would any of the other panelists like to comment on that subject?
Yeah, I can go next. So just like Karen, so we are also very concerned about this, and we were, from the beginning, we tried to formulate our project in a way that it's not something that actually overlaps with what like a physician do. But like the main goal of our project was to kind of provide an assistive tool which can be later used by the caregivers or the clinicians themselves, because nowadays we see like a huge trend in the research and machine learning research especially, that they want to have these algorithms replacing the physicians or the people who are making the decisions. And it has sparked like a huge debate currently. But in our project, we were kind of like from the beginning, we did not target to like replace the clinician part in the cycle. So basically what we tried to do was to actually add another source of information which can come from, let's say, the continuous monitoring using the smart home sensors to the physicians and caregivers and people who make important decisions.
Okay.
Okay, so for me, it's a little bit, and for my work, it's a little bit difficult to kind of say that, because they don't really ask me for or about anything like people don't really come and say, should I use something to reduce my fall-related injury? And that's a big distinction. I don't prevent falls. My work doesn't prevent the fall, right? My work prevents the injury when you fall. This is my supervisor's motto, right? Kind of like my work is the seatbelt. Traffic accidents are going to happen. It's going to happen to someone. It's an eventuality. As much as you try to avoid it, there's things like weather and that you can't, and other people that you can't avoid. It's going to happen, and you need a safety system there. So when it comes to, the bigger question I get is, a lot of people say, what can I do to prevent a fall? And I give them this exact answer: that's not my area of expertise. I can't tell you anything that you can do to prevent a fall. I can, however, give you tips, or I can give you products that can help you reduce your injuries from the fall. And it complements physicians well enough because it doesn't really affect them medically when they start using these products. The hip protector doesn't do anything. The worst thing it might do is give you a rash, right? In which case, you don't really need a physician to go and tell you to take something off that gives you a rash. The older adult is able to do that, or a PSW or a nurse. Same thing with the mat. The PSW or nurse would know if this is good for the resident, depending on their balance, their gait, and how likely they are to fall, right? They would know whether this is a good recommendation. And then finally, with safety flooring, there's really no downside to the residents. It's embedded underneath the floor, so it doesn't really do anything. It behaves and acts like a normal floor. You don't even know that it's there. So it's not really, there's not a lot of conflict when it comes to physician interaction with my work.
Okay. Olive, did you want to comment on this subject?
Well, I think most older adults look at the new technologies as enhancing what's already there. There may be some who are seeking answers. They don't know who to turn to. So if they are working with someone they think has some medical knowledge, then they're bound to ask. But they certainly would accept the fact that, what you're building is something to enhance what is already there and to make life easier for the older adult themselves.
Okay, good point. It's going to pop back into our Q&A box, and I see that Sienna has a question for Hadi and Mayank. To what extent has artificial intelligence, AI, been implemented into smart home technology solutions? It seems that AI is becoming more capable of handling ambiguity from users in order to promote ease of use.
Okay, exactly. That's actually a very, very important point, because the thing is that the important bottleneck in the AI research and the smart homes, I would say, was the lack of good data sets. So unlike other, fields that AI has succeeded in, for instance, like natural language processing or object recognition or face recognition, those fields, they do have access to, I would say, an unlimited amount of good annotated data. But with the smart homes, especially with healthy smart homes, the most important thing we need is the ground truth. As I said, one of the unique aspects of our work was we had access to the blood pressure, which was recorded using a medical device. But publicly, we do not have access to such a thing. And it has been a very huge bottleneck in limiting the power of AI in the smart homes. But currently, with having more research groups and I would say more interest in this field, we are also getting more data, and we will have more researchers working on that. But the thing is that in AI, we already do have good infrastructure in other fields to start with.
Okay. Thank you. Just looking across the boxes here with any other comment or questions. Anyone have any final questions they would like to pose to any or all of our panelists? No? Oh, wait, we do have a question here. Sorry. We have a question for Hadi from Farah. Farah asks, how do you manage the signals with people who have pacemaker or other parts replacement, hips, for example? This might interfere with the signals and affect your desired results.
Yes, that's actually a very, very good point that we need to consider in our project. So the thing is that in the data set that we already have, we did not have, it was actually an exclusion criteria. So if they had any pacemaker or anything, we could not get the data from them because at that point, like data was recorded in 5-6 years ago. We were not sure about the effects that like these smart homes might have on those devices. So it is actually, I would say, an open research question to see like to what extent they are actually interfering with the signals.
I think you're muted.
Oh, sorry, I was on mute. Edith is asking, typical smart homes are vulnerable to a high number of data attacks. How will you mitigate this?
So basically, I would say like the focus of my project was mostly on like building this like processing framework for the data. So that question is actually like another field of like thriving research, the cybersecurity field that is trying to kind of like reduces those attacks and try to have a more and safer infrastructure. So I would say in the current project, we did not use any cybersecurity measures, but definitely if we are looking to, let's say, implement this solution in, I would say, like a huge care facility, definitely there is something to consider for the security and like the cybersecurity parts.
Okay. And I just wonder in terms of maybe just we're kind of wrapping things up, if we can just go around the table, the virtual table, and if each of you could comment on what are your hopes for the future of age tech, you know, and you could comment in terms of your field specifically or in general, but what are your hopes for the future of age tech? Olive, would you like to begin?
For me, I think we have to start looking at ethics and making sure that everyone is protected. Age tech is a wonderful invention, but it's almost seems like it could get out of hand if we don't watch what goes on. And older adults, especially if it's things that's going to be going into their home, you really have to start looking at ethics and how you're going to deal with that, or how an older adult's going to deal with it. But I'm very excited about what is happening with technology, and I hope it's there when I need it.
Okay, Karen, how about you?
My hope is that we can use technology to strengthen connections and relationships and refigure, you know, systems and the places where we live to help us all live well and live healthy. I think a lot of digital technology, especially, there's been a mentality for quite a while, if not, you know, for decades, that you move fast and you break things, but where is the focus on repairing what's being broken? Right? Is that not just as important as making new things? You know, understanding what repair and rehabilitation means beyond the physical, but also, you know, for us in society, you know, the ways that we live, the places that we live, especially when we think about the climate crisis, and how we want future generations to live. That is really important. I think that, and I hope that's something that age tech considers more and more as we go on.
That's a great point. Mayank, would you like to go next?
Sure. So for my work, one of the biggest challenges with this is that there's currently that the cost sometimes goes on the resident, depending whether you're retirement or long-term care. So I would like more efforts in implementation as well as public health to make some of these interventions almost mandatory. So that, or, you know, at least government subsidized, government funded, so that they are more accessible. You started with the seatbelt being mandatory, then airbags were mandatory, then side airbags were mandatory, then rear airbags were mandatory. So as time went on, they realized that more safety interventions need to be put in a car. This needs to happen for older adult care facilities.
Okay, and last word to you, Hadi.
So my personal hope is that so far all the growth and all the improvements that we've seen were results of like a collective effort from engagement from all the stakeholders. So my personal hope is that we can actually envision a bright horizon for HTech if we can have like more people engaged in this, researchers from different fields, and like having a good plan and a clear plan of action for the future.
Okay, well, thank you all. Thanks to our panelists for a fantastic set of presentations today. We really appreciate it. A very diverse group of presentations and lots of stimulating discussion that followed. Really appreciate that. And I want to thank as well our AgeWell staff members for facilitating, setting this wonderful occasion for us to get together. And to all of you, please don't forget to register for the other EPIC conference sessions. That includes an EPIC workshop hosted by the Center for Implementation. And in the webinar chat box here on our Zoom call, you'll see that link again for registering. Don't forget to do that. So thanks to everyone involved, and look forward to seeing you at some of the upcoming presentations in this great EPIC program this year. So all the best and have a great day. Bye-bye now.